handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
So hi everyone, again, I'm Doc Shane, and I will be discussing OSI Part 2 of the reproductive system. So for me, my subjects naman are pathology, pharmacology, and microbiology. So sa pharmacology, I will focus on the obstetric cases. For pathology, gyne cases, kasi yun naman yung mostly na-operahan namin. And then for microbio, it will be a combination of obstetric and gynecologic infectious diseases. Okay? So let's start with pharmacology and obstetrics. So these are the high-yield topics in pharmacology. Okay, so this will be the outline of my lecture. So I'll start by discussing the drugs that are used during the early pregnancy complications or for early pregnancy complications. So under this, I will also be discussing GPN drugs, okay? So just to clarify, guys, ang GPN is not under obstetrics. But since it's very closely related to your molar pregnancy, I chose to discuss this along with the drugs used for molar pregnancy, all right? So next, I will be discussing drugs used for obstetrical complications, specifically for your hypertensive disorders and for preterm labor. Then finally, I will be discussing with you drugs used in the labor room. So I chose to focus on drugs used for labor induction and for obstetrical hemorrhage. Okay? So let's begin our discussion on pharmacology. But first, ano muna yung ifo-focus ko? So I will tell you what or which drugs to give. And instead of focusing on the how, ang mas gusto kong malaman nyo is why. Okay? Bakit yun yung particular drug na binibigay namin? Ano yung mechanism of action? Ano yung particular about that drug na binibigay namin siya during these cases, okay? Or for these cases. So, let's start. So, these are your high-yield drugs for early pregnancy complications. So, as usual, I always like starting with the case. So, we have OB, she's 31-year-old. She's G2P10101. So, take note, she has history of preterm delivery. Her chief complaint is hypogastric pain with spotting. So dapat nag-run na yung mind niya, no, kung ano yung mga differential diagnosis nyo. She's pregnancy uterine, 11 weeks, age of gestation. Ito yung mga pertinent na findings sa kanya. Her cervix is closed. Corpus is enlarged to 10 to 12 week size. So that is consistent with her amenorrhea or her LMP. On ultrasound, there was a single-line intrauterine pregnancy with minimal subchorionic hemorrhage. So first, what is your diagnosis? So you have closed cervix with live na intrauterine pregnancy. So you are dealing with a case of threatened abortion. Okay? Bakit threatened? Kasi buhay, tapos closed yung cervix. Pag patay yung embryo or wala at embryonic siya, that will be missed. Okay? Pag open yung cervix, dalawa lang, di ba? All eyes are open. It's either inevitable or incomplete. Okay, so ito, threatened abortion. Okay, so now this is my question for you. Which of the following drugs will promote uterine quiescence in this patient? Is it dydrogesterone, ethinyl estradiol, or dinoprostone? Okay, so mamaya babalikan natin tong question na to. But first, I will discuss with you yung physiology. Remember this, the phases of parturition. It starts with your conception and it ends with when your fertility is restored. Okay? So yun yung ending ng parturition. So yung phase 1 is the quiescence. I would like to focus on this phase of the parturition because during this phase, ang predominant na hormone mo is progesterone. Okay? So this is the hormone that maintains the uterine quiescence. So technically, meron ka ring estrogen during this part. But in this phase of your parturition, its effects are countered by your progesterone. Okay, so that's how important progesterone is, especially during the early parts of your pregnancy, prior to phase 2, 3, and 4. Okay, so ano ba ginagawa ng progesterone? So progesterone is the hormone, as I mentioned, that promotes or maintains uterine quiescence. So it lowers your CAPS. Ano ba yung CAPS? These are your contraction-associated proteins. Namely, these are your oxytocin receptor. So as you know, si oxytocin, this is the hormone that is primarily responsible for the contractions in your uterus. Prostaglandin F receptor. Tandaan niyo, di ba, nung AUB, I discussed this. Si F, pag AUB, friend mo yan, di ba? Si E, yung ayaw mo kasi siya yung enemy mo. But that is for AUB. Kasi si F, what does it do? It promotes contraction. So gusto mo siya sa AUB kasi when your uterus contracts, nagiging less yung bleeding. However, if you're dealing with an early pregnancy or a preterm pregnancy, ayaw mo syempre na nagko-contract siya. So ito yung pinapababa ng progesterone mo. Other than that, it also decreases concentrations or levels of connexin 43. Okay? Si connexin, so promethazine, connexin, so yan yung responsible for intercell communication. Okay? So kung papansinin niyo yung mga cells, sorry, hindi ako nag-drawing dito ng cell, hindi ako naglagay. But essentially, it promotes the communication from cell to cell. So pag mas maraming connexin mo, mas mataas yung chance na mag-contract yung uterus. Okay? So basically, si progesterone, binababaan niya all these proteins para hindi mag-contract yung uterus. Naget? So, progesterone versus estrogen. So anong difference nila? So si progesterone, it enhances oxytocin receptor degradation. Okay? Therefore, it inhibits the oxytocin activation at its receptor level. So, therefore, it promotes uterine quiescence. No? So, less yung uterine contraction mo when you give your progesterone or in the presence of progesterone. On the other hand, your estradiol, it raises myometrial oxytocin receptor concentration. So, kabaliktaran naman siya. So, siya naman yung nagpo-promote ng uterine contraction. So, ano yung gusto mo? Gusto mo syempre si progesterone yung mag-predominate during the early part of your pregnancy para hindi siya mag-preterm labor or mag-threaten abortion. Naget? Okay. Ayan. So I just like to clarify something. No? So doktora, you mean to say progesterone lang yung meron si patient during phase 1, phase 2, phase... Hindi, parehas na mataas ang progesterone at estrogen. It's just that the uterus is more responsive to, or it's responsive to both progesterone and estrogen during phase 1. So yung effect ni estrogen is naka-counter ni progesterone. Now, pagdating mo naman, pag halimbawa nag-labor ka na, may tinatawag kasi na unclassical progesterone withdrawal. Okay, bakit siya unclassical? Because technically, you're not withdrawing progesterone. Yung uterus mo, nagiging less responsive siya to progesterone. And when that happens during the latter phases of your parturition, yun na ang mitya. Okay? Yun na ang nagpapastart ng labor in your patients. Naget? So si progesterone, estrogen, parehas yan ha, parehas yung mataas. Even during the early parts of your pregnancy, yung responsiveness ng uterus, yung naiiba throughout your phases of parturition. Okay, so technically, you're not withdrawing progesterone dun sa latter phases, nag-iiba lang yung kanyang response. Okay? So, going back to the question, so alin dito yung progesterone? So, ang progesterone mo dito is the first one, dydrogesterone. Okay? So, isa yan sa mga common drugs that we give for patients in preterm labor or in threatened abortion. So obviously, you won't give your ethinyl estradiol and then your dinoprostone. This is a prostaglandin. So ito rin yung ayaw mo because your prostaglandin promotes uterine contractions and also restructuring of your cervix. Ito yung pang-ripen natin ng cervix. Okay? So ayaw nating magbigay syempre ng dinoprostone in a patient in threatened abortion kasi otherwise, magtutuloy yung abortion niya. Okay? So ano ba yung mga common na progesterone na ginagamit namin during pregnancy. So these are the common ones. Dydrogesterone is given orally. You have your micronized progesterone. So ito yung maririnig nyo, yung common brands nito is Utrogestan. Okay? So si Utrogestan, you can either give it per orem or intravaginally. Okay? May vaginal na preparation niya. So ano yung difference nitong dalawa? Technically, same lang yung efficacy, but yung per orem, hindi namin to binibigay kasi nakakaantok siya for patients. Okay? So mas preferred ko personally to give it vaginally. Now, your 17-hydroxyprogesterone, this is given intramuscularly. Okay, so these are the common progesterones that you give. So again, mas gusto kong maalala nyo yung the why instead of the how. Okay, so yung mga how, kayo na bahala niyan sa further readings nyo, and yung mga residents and consultants na yung bahala magturo sa inyo niyan. Ang mas important sa akin is mas mag-stick sa inyo why we give it, para mas maalala nyo yung concepts or pharmacologic concepts behind the drugs in pregnancy. Alright? Okay, so when else do we give progesterone? So nabanggit ko na yung isa, threatened abortion, preterm labor, parati ko itong nababanggit. We may also give them in cases with history of preterm labor. So for example, si patient natin, meron siyang prior preterm labor. So kaya siya importante sa history taking mo because you are more worried in these patients dahil baka mag-preterm labor din sila for the current pregnancy. So as a form of prophylaxis, we tend to give progesterone in cases of these patients as well. Alright? So sino pa? So if the patient will undergo a stressful procedure, so halimbawa, meron siyang ovarian new growth in pregnancy. So we don't want to disturb the corpus luteum, no? Especially kung nasa first trimester yan, like in the first 6 weeks or 7 weeks of pregnancy, tapos she will undergo an ovarian surgery. So nandun pa yung corpus luteum mo, di ba? Remember, your placenta during this time is not yet mature enough to produce your progesterone. So, ang nangyayari is, yung corpus luteum has to be maintained by your beta HCG, okay, which comes from your developing placenta. So, because of that, you have to supplement your progesterone. Why? Kasi kapag na-disturb mo yung corpus luteum, which is inside your one of your ovaries, pwede kang mag-abort. So, kaya for these cases, we give prophylaxis in the form of progesterone. Naget nyo? Naget nyo bakit tayo magbibigay ng progesterone sa kanila? Kasi pwede mong ma-withdraw yung source ng progesterone, which is your corpus luteum. Okay? So these are the things, these are just some of the instances when we give progesterone in our patients. Alright. So, balik tayo dun kay patient, no? So, nakita mo na si patient, binigyan ng resident mo ng 2 drugs. So, she gave progesterone. So, dydrogesterone. So, this is the dose. 3 times a day for the next 7 days. Aside from that, she also gave isoxaprine. 10 milligrams per tab, 1 tab, 3 times a day for 7 days. So, doktora, ano naman yung isoxaprine? Bakit tayo may pa-isoxaprine sa kanya? So, balikan natin kung ano yung mga beta-adrenergic receptors because your isoxaprine is a beta-2 agonist. Okay? So, ang dalawa lang naman talaga na commonly naririnig natin si beta-1 saka si beta-2. So, si beta-1, these are the receptors found in your heart and your kidneys. So, ang goal ng beta-1 pag siya ay na-stimulate, it will increase the heart rate. Sa kidneys naman, ang end result niya, it will increase the BP. Okay? So, kapag single ka pa, nakakita ka ng crush mo, so number 1 siya sa heart mo. So, tumataas ang heart rate mo, pati ang BP mo. Pero, kapag kayo na, so dalawa na kayo, relax ka na yan. Okay? So, si beta-2 naman, saan siya nakikita? So, nakikita siya sa lungs. So in the lungs, since relaxed na siya, there is bronchodilation. Okay? And also in the smooth muscles, such as your GI muscles and your uterine muscles. And in your pancreas. So it increases your insulin. So Yan, so kumbaga sweet na kayo kasi kayong dalawa na eh. Yun. So anyway, in yung beta-2 receptors, when it is stimulated, it causes, in general, relaxation. Okay, yung isipin nyo, relaxation. Relax muscles, relax lungs, so may bronchodilation, and then so good siya for your cases of asthma. And then syempre, good din siya for cases of preterm labor or threatened abortion because it promotes uterine relaxation. Okay? So, ang mga examples natin ng beta-2 agonists are your isoxaprine and terbutaline. So, ito yung dalawang common. So, babalikan po ulit to si isoxaprine and terbutaline later on for your OB complications drug. So, nag-get kung bakit beta-2 agonist yung ibibigay natin. So, beta-2, kayong dalawa na, so relax ka na. So, okay, let's move on from that case. We have case 2, a 24-year-old primigravid. So, she's pregnancy test positive, she's asymptomatic, and ito yung mga other pertinent sa history and PE niya and the rest of your workup. So, she has no comorbidities, all remarkable yung IE sa kanya, so small uterus, wala namang adnexal mass or tenderness. And then on ultrasound, however, you saw that the gestational sac with no embryo, so gestational sac lang siya, is in the right adnexal area with this size. No? So you have an adnexal mass which is less than 3 centimeters in size, and your beta HCG is 3,000 milli-IU per ml. So what is your diagnosis? So obviously, no, so ito na yung giveaway mo. Gestational sac with no embryo na wala sa uterus. So obviously, this is a case of ectopic pregnancy, most likely tubal because of the location in the adnexal area, unruptured kasi asymptomatic, unremarkable, i.e., there are no findings or nothing in your history that points to rupture. So this is unruptured ectopic pregnancy. So again, ano yung mga options mo for management? You can do medical, surgical, or expectant. So for this patient, we chose medical management using methotrexate. So tingnan mo muna kung pasok siya sa criteria. So mukha naman pasok, no? Because she's asymptomatic, she's hemodynamically stable, hopefully compliant as well to monitoring, with low initial beta HCG kasi di ba ang patient mo 3,000 lang yung beta HCG, small ectopic pregnancy kasi less than 3.5, so pasok si patient less than 3 centimeters. No fetal cardiac activity, so obviously wala tong fetal cardiac activity kasi wala ngang embryo, gestational sac lang. So pasok siya sa pang-medical management. So why not surgical? Well, technically pwede mo naman siyang i-surgical, pero pwede mo naman din kasi siyang i-medical. So doon na lang tayo sa more conservative, which is medical management. So again, let's review ano yung mechanism of action of your methotrexate. It inhibits your dihydrofolate reductase. Okay? So dihydrofolate reductase meaning it prevents the reduction of your dihydrofolate to tetrahydrofolate. So ano ba yung importance ni tetrahydrofolate? Si tetrahydrofolate, it's a coenzyme for your purine and pyrimidine synthesis. Therefore, it arrests your DNA and RNA and protein synthesis. Okay? Nag-get? So important to. This is the enzyme that it inhibits, dihydrofolate reductase. So madali na lang siyang i-deduce. Kaya siya dihydrofolate reductase because it prevents the reduction of your dihydrofolate. Okay? So, how do you give your methotrexate? So it's usually given intramuscularly. So you can give it either single dose or via multi-dose regimen. So by single dose, ang gamit sa kanya is the body surface area or your BSA. Okay? Si multiple dose, milligram per kilogram. Okay? Huwag kayong malilito doon. Si BSA, mas complicated yung complication sa kanya. Yung computation sa kanya. So ito yung formula na ginagamit natin usually, the Monsteller formula. So it is the square root of your height in centimeters times weight in kilos all over 3,600. So this is how we compute your BSA or your body surface area. So yan yung pang single dose. Okay, so ito yung dose mo for single dose, 50 milligrams per meter squared. For your multi-dose, 1 milligram per kilogram. So on odd days, you give your methotrexate. Your folinic acid or your leucovorin, you give that on even days to reduce the side effects of your methotrexate. So that's given 0.1 milligram per kilogram. So ano ang importante dito? Yung beta-HCG monitoring. Kaya important na compliant si patient. Yung iba kaya nila ayaw itong gawin kasi ayaw nila yung paulit-ulit na magbe-beta-HCG monitoring. So when do you monitor your beta-HCG? So you monitor it day 1. So that's your baseline. That's the day when you give your methotrexate. Day 4 and day 7 for single dose. So ang importante dito, hindi yung between day 1 and day 4. Okay? Ang tinitingnan namin is yung difference ni day 4 and day 7. So dapat ang goal natin ay more than 15% yung i-decrease ng beta-HCG mo from day 4 to day 7. Na-get? So okay lang kung hindi pa 15% yung decrease mo from day 1 to day 4 as long as yung decrease mo between days 4 and day 7 ay more than 15%. Okay? Yun yung goal natin. So, dito naman sa multiple dose, hindi ka naman magbibigay all days. Ang gagawin mo kasi, titingnan mo yung day 1, di ba? Then you give folinic acid on day 2, and then you check again on day 3. So, sa day 3, kapag more than 15% naman yung decrease niya, pwede ka nang mag-weekly monitoring ng beta-HCG. Otherwise, halimbawa, 10% lang yung decrease niya. So, therefore, aabot ka sa day 4, magbibigay ka ng leucovorin. Tapos sa day 5 ulit, magbibigay ka ng iyong, what you call this, methotrexate. Alright? Intindihan? So, yun yung mga indications mo for further doses. Yan. So, ito example natin. For example, you have a patient who's 50 kilos, 155 cms in height. So, check nyo na lang yung using the Monsteller formula. Pero ito yung na-compute ko. 1.56 meters squared ang kanyang BSA. So, paano mo ibibigay yung methotrexate? So, syempre, hindi mo naman sasabihin sa nurse yan na 50 milligrams per meter squared po yung ibibigay nyo. Dapat i-compute nyo na siya for the nurses kung ilan yung ibibigay nila na methotrexate. So, how do you compute that? So, ang usual preparation mo ng methotrexate, or syempre, you check the bottle first or the vial, it's usually 50 milligrams per 2 ml. So, that's the concentration or the formula of your methotrexate. So, ito yung computation natin, guys. So, 50 milligrams per meter squared times your BSA. So, that's 156 meters squared times 2 ml over 50 milligrams. So, bakit ganyan? No? So, parang by stoichiometry, diba? So, makakancel to si meter squared, si milligrams, makakancel to, diba? By stoichiometry. Yan. So, matitira si ml. So, by computation, if you compute it, 3.12 ml, mga 3.1 ml, or 3.15 ml, ganyan. Yan yung ibibigay mo sa patient mo na in ml of methotrexate. Na-get? So, ayan. So, yan yung sample na paano mo ibibigay si methotrexate. And then you give that IM, intramuscularly. Okay, so let's move on. So, binigay ko na yung diagnosis natin. Pero let's review pa rin. So you have case 3, Maria. She's 42-year-old. She's multigravid. She's G9P8. Came in profusely bleeding with passage of vesicular tissue. So obvious na obvious, molar pregnancy yung pinatutunguhan nito. Pero ito yung mga ipang important sa kanya. She's 8 weeks by LMP, but her corpus size is 16 weeks size. So may difference ka na 8 weeks between your LMP and your corpus size. And then she underwent emergency suction curettage kasi profusely bleeding na siya, open na yung cervix. So, emergency suction curettage yung resident mo. And this is your baseline beta-HCG, no? Kasi sure naman na kayo na molar pregnancy to based on the presentation of the patient. It's 150,000 milli-IU per ml. So this is the other instance when we use methotrexate in obstetrics, no? So for molar pregnancy as a form of chemoprophylaxis. Prophylaxis for what? So remember, your molar pregnancy can transform into GTN, which is the malignant form of your molar pregnancies. Okay? So to prevent that, we give your methotrexate. So isa lang dito sa mga to yung kailangan niyang i-fulfill para siya ay mabigyan ng methotrexate as a form of chemoprophylaxis. So this is taken from the CPG of PSTD, which is the Society for Tropho Specialists. No? So si patient, ito yung firstly pa lang na fulfill na niya. Our patient is 42 years old. And then, di ba, I emphasized this kanina, 8 weeks yung difference ng uterine size with their age of gestation, no? 8 weeks tapos 16 weeks. So, malaki yung size, kumbaga, ng uterus mo compared to your computed gestational age. And her beta HCG is more than 100,000. So, yung sa kanya, di ba, 150. So, marami siya. So, 3 out of the 7 criteria na fulfill niya. So, for this patient, you should definitely give methotrexate. Yeah, so how do you give methotrexate in molar pregnancy? Take note, iba siya, guys, sa ectopic pregnancy. Okay? So, you give it 0.3 to 0.4 milligrams per kilogram per day intramuscularly for 5 days. Sunod-sunod yan. Okay? So, unlike your multi-dose for ectopic pregnancy na kailangan tingnan mo muna yung beta HCG, depende pa kung magbibigay ka further doses. Ito, guys, kailangan 5 days straight. Mabibigyan siya ng 0.3 to 0.4. Hindi 1 milligram, hindi 15. Okay? 0.3 to 0.4 mkd, milligrams per kilogram per day. So review lang natin, ito yung sa ectopic pregnancy. This is for your single dose. This is for your multiple dose regimen. So again, what is the effect of your methotrexate? Because it is able to arrest DNA, RNA, and protein synthesis, it is highly effective against your rapidly proliferating tissues such as your trophoblast. So because it is highly effective against your rapidly proliferating tissues, syempre hindi lang siya sa trophoblast mag-e-effect. Mag-e-effect din siya in other tissues that are also rapidly proliferating. So example, in your bone marrow, so magkakaroon ka ng myelosuppression. So because of this, ang mapapansin nyo yung mga patients na nagme-methotrexate, ang baba ng WBC nila or mababa din yung kanilang hemoglobin. It's because of this side effect to your bone marrow. They also present with side effects to your GI mucosa. So ano yung usual chief complaint ng mga patients na nagme-methotrexate? They have stomatitis, nagkakasingaw sila. So ito yung mga isa sa mga ayaw natin, no? Respiratory epithelium. If side effect to the respiratory epithelium, specifically they present with difficulty of breathing. So yung mga post-methotrexate patients nyo na nagiging dyspneic right after you give your methotrexate, consider an adverse effect secondary to your methotrexate. They also have effects on your hepatocytes and it is renally excreted. So therefore, importante nagmo-monitor tayo ng creatinine sa patients na naka-methotrexate. Okay. So because we know that your molar pregnancies can later on progress to GPN, especially if it's complete mole. Remember, ang mas gusto natin is si partial versus complete. Dahil si complete, mas mataas yung chance niya mag-develop into GPN, which is malignant. Ano ba yung GPN? So first, I'll give you a case. So for example, si patient mo na to, so G9P88018 na siya. Okay? So one dito is yung kanyang molar pregnancy. So she underwent suction curettage for complete hydatidiform mole. So mas mataas yung chance niya magka-GTN 3 months prior. However, hindi siya nabigyan ng chemoprophylaxis. So she was not given methotrexate post-curettage. And then she came into you with persistent bleeding for 2 weeks. So dahil may history siya ng molar pregnancy, nagbi-bleed yung patient, ang iniisip mo na, baka naman nagkaroon na ng GTN to si patient, no? So true enough, on beta HCG, you saw that her serum beta HCG is 100,000 milli-IU per ml. So this is elevated. And then on workup, you saw that she has an endometrial mass on transvaginal ultrasound and she has a violaceous nodule in the vagina. Okay? No lesions on chest imaging. So on chest x-ray, pati chest CT scan, wala kayong nakitang signs of metastasis there. Pero meron siyang violaceous nodule sa vagina. So itong patient na to, you diagnose her to have GTN or gestational trophoblastic neoplasia. Itong si violaceous nodule sa vagina, kailangan mo ba itong i-biopsy? no. Okay? So, pag tinanong kayo ng consultant or ng resident na in the background na GTN yung diagnosis mo sa patient, you don't have to, or actually you should not biopsy this violaceous nodule in the vagina just to confirm if it is a metastasis from your GTN. Okay, why? Kasi malakas ang chance na mag-bleed tong violaceous nodule na to. So, hindi mo siya gagalawin. Okay? You assume that it is a metastasis from your GTN. Okay, so what is GTN? So, bulk of your GTN or gestational trophoblastic neoplasia tumors are persistent molar pregnancies or invasive molar pregnancies. So, that's around 75%. So, 3 out of 4. So postmolar GTN is more common, as I mentioned, in cases of complete than in partial H-mode. Okay, so kaya mas ayaw natin yung complete H-mode. Ito ang importante sa GTN, guys. In GTN, hindi mo kailangan ng histologic diagnosis. So yung nakita mo na endometrial mass, hindi mo yan kailangang i-biopsy. In fact, hindi namin yan ibabiopsy dahil madugo yan. Okay? So in cases of GTN, your clinical presentation has more important impact than the actual histology. Meaning we don't need to take a biopsy sample from an endometrial mass just to say that it is a case of GTN. Hindi namin kailangan ng histopathology confirmation for that. Enough na nagpa-plateau or nag-rise yung HCG levels niya post-molar evacuation for us to label a patient as GTN. Na-get? So unlike your other cancers like your cervical carcinoma or your endometrial carcinoma na kailangan namin kumuha ng tissue samples and to get a histologic confirmation of the disease, ang GTN lang ang for us ang type of cancer na enough na yung beta HCG monitoring for us to label them as cancer. Na-get? Okay, so for example, di ba may endometrial mass yung patient natin, saka meron din siyang vaginal nodule. We don't have to biopsy those. In fact, hindi mo talaga siya iba-biopsy because otherwise you would incur hemorrhage in these patients. No? That's how dangerous those GTN tumors are. Okay, so ito yung workup natin for GTN. So I'd like to emphasize itong serum HCG levels kasi it's very important, no? Ito pa lang kasi makikita na namin yung diagnosis namin na GTN, plus it will also tell us the response to chemotherapy. Ayan. So ano ba yung staging ng GTN? So madali lang ang staging ng GTN, guys, okay? So si GTN stage 1, it's confined to the uterus. Stage 2, outside the uterus, but they're all genital structures. So si patient natin, stage 2 na siya kasi meron siya sa vagina. Okay? Stage 3, kung papansinin nyo, it extends to the lungs. Bakit to the lungs? No? Diba sa ibang mga cancer, pag halimbawa, cervical cancer na meron kang lung metastasis, automatic stage 4 na yon. Si GTN, guys, unique siya in that kapag meron kang metastasis to the lungs, that's still just stage 3. Okay? Kasi isa siya sa mga expected sites mo ng metastasis. So hindi mataas yung staging ng lung metastasis for cases of GTN. Okay, so with or without genital tract involvement. So kapag meron kang high beta HCG, tapos meron kang cannonball lesion sa lungs mo, tapos based sa history mo kang GTN si patient, pwede mo na siyang i-label as GTN stage 3. Diseases involving other sites, that's stage 4 already. So yun yung unique kay GTN. Si lung involvement is only stage 3 instead of the usual stage 4. Yan. So, di ba ang sabi natin, yung histologic diagnosis na is not as important as the clinical picture of the patient. So we have what we call your WH4 prognostic scoring system. So we score a patient from 0, 1 to 4 based on these parameters or risk factors. So hindi ko na iisa-isahin, guys. Basta ito yung mga risk, ito yung table na to, take a screenshot of this or meron naman to online and meron nito sa CPG namin. This is how we score a patient. Ang importante dito, guys, ano ang ibig sabihin ng WHO prognostic scoring? Ang maganda sa GTN, guys, it is extremely sensitive to your chemotherapy, no? So we only need to see the lowering of the beta HCG for us to say na nag-respond well si patient. Okay? So yun yung maganda kay GTN. So yung patients are classified into low risk or high risk. So, di ba ito 0, 1, 2, 4 siya. So i-add mo lahat ng score. Kapag ang score niya ay 0 to 6, she's considered low risk. Greater than or equal to 7, she's considered high risk. So bakit importante na i-classify yung patients into low risk or high risk? Kasi magmamatter siya in terms of chemotherapy for these patients. So this patient, diba, so sabihin na natin siya ay GTN stage 2, prognostic score of 5. Kumari, ito na yung na-score mo. So this is considered, bakit siya stage 2? Kasi meron siyang pelvic, meron siyang genital structure na metastasis, which is in your vagina. O kunwari, ang prognostic score niya based on the WHO prognostic scoring, it's 5, no? So dito namin sinusulat yung diagnosis. We start with the stage, colon, the prognostic score. So that's how important your WHO prognostic scoring is. Kasama siya sa diagnosis talaga. So dahil WHO prognostic score of 5 lang siya, it means na low risk yung patient. So anong implication nun? Pwede mo na lang siyang bigyan ng single agent chemotherapy. Okay, so ang single agent chemotherapy, ang choices mo dyan ay methotrexate or actinomycin D. Ang first line natin is your methotrexate. So kita nyo, favorite chemotherapeutic drug talaga namin siya. So siya yung first line mo for your low risk patients. So yung mga 0 to 6 yung score on prognostic score. For high risk patients, kahit pa stage, sabihin natin stage 2 lang siya, pero ang WHO prognostic score niya ay 9. You give your multi-agent chemotherapy already. That's your EMACO. So mamaya, sabihin ko sa inyo kung ano tong components ng EMACO. So see, kaya magmamatter kung ano yung prognostic score niya. Kasi depende doon kung isang chemotherapy drug lang or multi-agent yung ibibigay mo. So these are the usual drugs that we use for your GTN patients. So si EMACO is ito. Kaya siya EMACO. Kasi etoposide, methotrexate, actinomycin, cyclophosphamide, and si vincristine. Okay? So bakit siya O, doktora? Kasi Oncovin yung isa sa mga pioneering brands ng vincristine. So ito yung EMACO. So di ko naman sa inyo i-discuss yung full regimen ng EMACO, pero gusto ko na alam nyo kung paano binibigay yung methotrexate in low risk or non-metastatic GTM. So we give it same dose ng chemoprophylaxis mo in molar pregnancy, no? So 0.3 to 0.4 milligrams per kilogram per day intramuscularly for 5 straight days, okay? 5 consecutive days. So may mga other regimens which are your pulse. Ito, kung titingnan nyo yung dose niya, similar to your single dose treatment for ectopic pregnancy. And meron ding 8-day regimen na kung titingnan mo siya, same siya halos dun sa multi-dose ng ectopic pregnancy. Pero among these three, ang pinaka makikita mo in practice is itong 0.3 to 0.4 mkd IM for 5 days. So para ka nagbigay ng chemoprophylaxis in molar pregnancy. Okay? So now, let me introduce to you Chemoman. Okay? Si Chemoman, siya yung mnemonic namin or parang siya yung cartoon namin to help us remember your chemotherapy toxicities. Okay, so isa-isahin natin si Chemoman. So itong C dito, itong nasa ear niya, that stands for your ototoxicity seen in cisplatin. So meron ka ding C dito sa kidneys mo because it's also nephrotoxic. Okay? Si M tong mouth niya kasi stomatitis. So that's for your methotrexate. Si B, bleomycin. Okay? Sa lungs naman because your bleomycin can cause pulmonary fibrosis. Si doxorubicin is ito, yung nasa heart. Okay? Letter D siya because it can cause cardiac toxicity. That's why yung mga patients na nagdo-doxorubicin, usually may mga cardio clearance yan. Okay? Si cyclophosphamide, ito siya, C tapos may Y. Cyclophosphamide. Because it can cause hemorrhagic cystitis. Si V, ito, si vincristine, vinblastine, ayan. Kaya siya V na ganyan. Kesa dyan because it can cause peripheral neuropathy. Ngayon, may dinagdag ako kay chemo man, which is ito, si letter A. Kunwari, yan yung buhok niya. A, si actinomycin. Because this is the chemo drug that is notorious for causing alopecia in your patients. So usually yung mga patients namin na may GTN, pag first line pa lang, yung methotrexate pa lang, ang concern nila kung makakalbo ba sila. Hindi sila usually nakakalbo with methotrexate, pero once they start with the second line, halimbawa, di nag-work yung methotrexate, we go to the second line, which is actinomycin, dun sila nag-alopecia. Okay? So yeah, so we're done with the first trimester drugs in the early pregnancy complications. We'll now go to the latter OB complications. So hypertensive disorders, we have an 18-year-old preemie gravid. She's 32 weeks, not in labor. Known case of gestational hypertension. So this is her maintenance drug. So methyl-dopa 250 milligrams twice a day. So she's asymptomatic with good fetal heart tones, pero pina-ER siya ng OB niya. Why? Because elevated ang BP niya, 160/100, with stacked albumin of +1. So nag-persist yung elevated BP niya, kaya siya pina-ER nung OB niya. Because she has a systolic BP of at least 160, you now label this patient as a case of preeclampsia with severe features. So for this patient, you decided to admit the patient. So you secured IV access in this patient and you gave hydralazine, 5 milligrams IV. So this was able to decrease the BP of the patient to 140/90. You inserted indwelling Foley catheter. Baseline labs were sent for this patient, and she was also given loading dose of magnesium sulfate and dexamethasone. So ano tong mga naka-red? Ito yung mga drugs na iisa-isahin kong i-discuss sa inyo. Okay? So kasama na dito si methyl-dopa. So these are the commonly used antihypertensive drugs in pregnancy. So hindi ko na to iisa-isahin pa ng basa kasi mamaya iisa-isahin ko sila in terms of mechanism of action. Okay? So note silabetolol. Kaya ko siya minention na yung mechanism of action nito kasi hindi ko na siya i-mention dun sa table ko. Why? Kasi silabetolol is not readily available in the Philippines. So ano ang mechanism of action ni labetalol? It is a non-selective beta-blocking agent. So it blocks both beta-1 and beta-2, but more of si beta-1 yung binablock niya. Remember, si beta-1, nung single pa siya, tapos may crush siya. So ang number 1 sa kanya is nasa puso niya, yung crush niya. So di ba, isa sa mga effects ni beta-1 is that it increases the heart rate and then the BP also. Okay? So when you block your beta-1, it will decrease the BP. Okay? It's also a vascular alpha-1 receptor blocker. So si alpha-1 receptor, mamaya i-discuss ko rin yan, pero ang effect niya ay nasa vascular smooth muscles. So si alpha-1, it vasoconstricts, no? So when it blocks the vasoconstriction, the vasodilation will cause decrease in BP. Okay? So dinidescribe ko na si labetalol ngayon dahil hindi ko na siya i-describe mamaya pa sa table. Pwede ba sa pregnancy yung mga ACE inhibitors mo, yung mga PRIS, mga captopril, and yung mga ARBs, ganyan, yung mga losartan, ganyan, telmisartan, pwede ba yon? Sila yung mga hindi binibigay mo sa pregnant patients, okay? So, meron kasi siyang adverse effects sa renal vasculature ni baby. So, sila yung mga nag-uuligo. So, as much as possible, actually, we don't give these at all. Yung ACE inhibitors and ARBs, no yan, alright? So, ito yung mga pwede mong ibigay. Ito yung mga usually binibigay namin in pregnancy. So, yan, isa-isahin lang natin. So, ang pinaka-common na binibigay namin as a form of maintenance medication is your methyl-dopa. Your methyl-dopa, it's a centrally acting alpha-2 receptor agonist. So mamaya, i-discuss ko rin yan. So ito ang usual route of delivery niya is per RM. So you start with 500 milligrams. Kasi patient kanina, di ba, 250 milligrams BID. So 500 milligrams yun per day. So maximum dose mo sa kanya is 3,000 milligrams. So, ang pertinent na side effect niya is depression. This is also the reason why yung mga postpartum patients natin, di ba, kung papansin niyo, hindi namin sila binibigyan ng methyl-dopa postpartum. Why? Because during the postpartum period, biglang bagsak lahat ng hormones mo. Bagsak si progesterone, bagsak si estrogen, bagsak si oxytocin. So dahil sa pagbagsak ng mga hormones na yon, your patients are more prone to postpartum blues or postpartum depression. So sa kanila, hindi mo na exacerbate yung risk na yon by giving your methyl dopa. So allowable lang siya, bigay lang namin siya kapag buntis pa si patient. So your other drug that is commonly used is your hydralazine. So this is a direct vasodilator. So mas mabilis yung effect niya compared kay methyl dopa. That's why do sa patient na may hypertensive urgency in pregnancy, nag-secure agad ng IV access sa kanya, nagpabigay agad ng hydralazine. So ang starting dose na ay 5 mg IV or IM, we usually give it IV. Ano ang mga side effects niya? So imagine pag nag-vasodilate ka, so pati yung mga veins sa utak mo magbabasodilate yan. So this can cause headache. It can also cause palpitations because of your increased heart rate and flushing. Okay? So the other class of drug that you can give in your pregnant patients who are hypertensive are your calcium channel blockers. So examples nun are your oral nifedipine and your nicardipine, which is usually given in drip. Okay? Ito yung, hindi ko na i-ano to guys ha, kayo na bahala to. Kayo na bahala magbasa nito. Ito yung preparation ng nicardipine drip. Ito yung usual dose mo for nifedipine. So bakit calcium channel blockers? Paano siya nakaka-cause ng lowered blood pressure? Because it prevents the influx of your calcium. What happens is nagva-vasodilate or nagre-relax yung vascular smooth muscles mo, no? So ang end effect niya, it will cause decreased BP. So ano naman yung side effects niya? Very similar sila ni hydralazine, no? So they can cause tachycardia, palpitations, flushing, edema, kasi nag-vasodilate ka eh. And then headache also. So halos same sila ng side effects ni hydralazine. Okay, so review lang natin yung mga alpha-adrenergic receptors. So when you say alpha-adrenergic receptors, you are either dealing with alpha-1 or alpha-2. Okay? Si alpha-1, nasa periphery yan, more of sa vascular smooth muscles. So kapag na-stimulate yung alpha-1 receptors mo, there is vasoconstriction. Si alpha-2 naman, it's more central, no? Meron siya sa brain, meron din siyang peripheral side effect, and it inhibits your sympathetic activity, lowering your BP. Remember na si methyl dopa mo, it's alpha-2 receptor agonist, no? So, sinestimulate niya si alpha-2, therefore, ang end effect niya is lower BP. Okay? Ayan. So, ito yung isa pang drug na binigay mo kay patient. So, you gave her magnesium sulfate. So, remember from our discussion dun sa mga preeclampsia, gestational hypertension, etc., your magnesium sulfate is both an anticonvulsant and it also has neuroprotective effects, okay, for both the baby and the fetus. So these are the proposed mechanisms of action of your magnesium sulfate, how it becomes an anticonvulsant and a neuroprotective drug. Okay? So hindi ko na isa-isahin, but I would like to emphasize na it blocks calcium entry, no? So anti-calcium influx din siya. So mamaya babalikan natin yan sa later discussion natin. And it decreases the effects or the concentration of your neurotransmitters, no? Or yung minsan nag-e-effect siya sa receptors ng mga neurotransmitters. So one good way of describing kasi convulsions or seizures to your patients is para mong piniprito yung utak every time nagsiseize yung patients, okay? So every time ina-explain ko that way yung seizure or convulsions to the patients, mas naiintindihan nila kung ano yung nangyayari doon sa patient. Kaya ayaw namin na mag-progress to eclampsia yung mga patients namin. So, para ma-prevent or ma-lessen yung pagpiprito na yun, okay? So, magbibigay ka ng magnesium sulfate to lessen the effect or to prevent that from happening. Okay, so when do you give magnesium sulfate? You give them in cases with severe features na pre-eclampsia and in cases of eclampsia. So, nauwi na siya sa eclampsia, hindi lang siya pre, okay? So yan yung mga cases when you give your magnesium sulfate. And these are the ways by which you should give your magnesium sulfate. Doktora, kailangan po ba namin to i-memorize? For your rotation, yes. For your future practice, yes again. Okay? Kahit at least yung loading dose lang yung maalala nyo from this lecture and sa future nyo. Why? Kasi imagine if you're a doctor to the barrio or you're in a primary hospital. So kung meron kang patient with preeclampsia with severe features or merong eclampsia, tapos yung hospital mo or yung institution mo is not capable of catering to these patients, at least mabigyan mo sila ng loading dose prior to transfer. Okay? Malaking tulong na yun sa patients natin. Yan. So medyo nakakalitong, nakaka-overwhelm kung titingnan nyo yun. So ito na lang, isa-summarize ko for you guys. So how do you give your magnesium sulfate? So may dalawang ways. Yung una, yung maintenance dose niya is IM. Every 4 hours for the next 24 hours. Yung isa is via IV infusion, 1 to 2 grams per hour for the next 24 hours. So paano yung loading dose nila? So magkaiba yung loading dose nila, pero same yung IV na dose, no? So may IV component kasi yung loading dose nitong IM na maintenance. So 4 grams, slow IV push over 5 to 10 minutes, then 5 grams deep IM on the upper outer quadrant of each buttocks, no? So bakit sa upper outer quadrant ka nag-i-inject? Para maiwasan mo si sciatic nerve. So both wet, lalagyan mo niyang magnesium sulfate. So this is extremely painful for the patient. So isa sa mga irereklamo sa iyo ng patient kapag nagbigay ka ng IV na magnesium sulfate, sobrang init ng pakiramdam nila. So yun yung number 1 na mafe-feel nila when you give your magnesium sulfate. Now, for your IV infusion maintenance, your loading dose is also 4 grams. So you can either give it via slow IV push or minsan nilalagay siya in 100 ml of diluent. Tapos yun yung ipaparun mo for your loading dose. So between the two of them, syempre yung less painful is the IV infusion. Although some doctors prefer the IM because mas simple siya as a route of delivery versus your IV infusion na kailangan strictly infusion pump. Pwede rin namang hindi, although it would be less accurate. And kailangan maayos yung pagkakatimpla mo ng magnesium sulfate na infusion. Okay? So ito yung mga i-watch out for mo. You have to watch out for decreased urine output. So it should be at least 30 ml per hour or 100 ml for the past 4 hours. So dapat bago ka mag-IM, dapat nakita mo muna na 100 ml for the past 4 hours yung nasa urine bag niya, di ba? Remember si patient natin upon admission, if alam mo na nabibigyan mo siya ng magnesium sulfate, mag-i-insert ka na ng indwelling Foley catheter because this is one of the things that we monitor in our patients. You should also occasionally check for your patellar reflexes. So dapat may patellar reflex ka. And your respiratory rate should not be depressed or decrease in your patients na binibigyan mo ng magnesium sulfate. So ano ba kasi yung iniiwasan natin? Magnesium sulfate toxicity. And it typically appears to you in the form of loss of patellar reflexes or worse, dyspnea kasi na-depress na yung pati yung respiratory muscles niya. Diba? Remember, it prevents your intracellular influx of calcium. So, ang nagiging end effect niya, aside from decreasing your reflexes, kasi diba, it has an effect on your neurotransmitters, on the receptors. So, una niya itong i-affect, no? Si reflexes. Pero kapag halimbawa magnesium toxicity ka na talaga, magkakaroon ka na ng respiratory depression or worse, cardiorespiratory arrest. Okay? So pwedeng mag-code yung patient mo kapag nagkaroon siya ng magnesium sulfate toxicity. So what is your antidote to that? It's your calcium gluconate IV. Okay? So dapat lahat ng magnesium sulfate mo, meron kang bedside na calcium carbonate. It's 10 ml of 10% solution. So that is equivalent to 1 gram of your calcium gluconate. Huwag kayong malilito dito guys sa tinatanong to sa boards. 10 ml of 10% solution. Pero ang equivalent lang nun is 1 gram of your calcium carbonate. Gluconate, sorry. So ideally, you should have that bedside because kapag nagkaroon ka ng patient na kabibigay mo lang ng magnesium sulfate, biglang nag-DOB, bigay ka kagad nito. Okay? To counter the effects of your magnesium sulfate. Okay, so ano ba kasi ang goal natin? So ang goal natin in terms of milligram per ml is to reach this serum concentration of 4.8 to 8.4. Why? Higher than this, you get your CNS depression. So mauuna muna yung sa nervous system, no? So mga neurotransmitters and your neurotransmitter receptors, yan muna yung una niyang ide-depress. So ang una niyong makikita talaga is itong mga loss of DTRs in terms of yung mga minomonitor mo, ha? And then later on, decrease RR na yan. So mahihirapan na sila, pati yung respiratory muscles nila mapaparalyze, madedepress, and eventually, pwede yang mag-lead to cardiac arrest, as I mentioned a while ago. So note guys na important dito yung unit. So in terms of milligram per ml, ang goal mo is 4.8 to 8.4. Binaliktad mo lang si 4 sa kasi 8. Pero in terms of mEq per liter, it's 4 to 7. In terms of millimoles per liter, it's 2 to 3. So ito yung mga possible questions sa inyo sa boards. Ano yung therapeutic concentration ng magnesium sulfate or ano yung goal mo? It's 4.8 to 8.4 milligrams per deciliter. So babalik na rin mo lang siya. But more commonly, ito yung mas tinatanong, si 4 to 7 mEq per liter. Right? Ayan. So tapos na natin si hydralazine, itong si direct vasodilator, saka si magnesium sulfate. Ang last na lang na hindi natin na-discuss ng mga drugs na binigay sa patient mo is your dexamethasone. Remember, this patient is less than 34 weeks. I think 32 weeks yung nasa case ko, no? So, binigyan siya ng steroids, okay? Dexamethasone. So, para saan ba yung steroid therapy? So, your steroids, specifically your glucocorticoids, they are given between 24 to 34 weeks. Although may evidence na meron daw slight benefit even up to 37 weeks or 36 and 6 days. Okay? 36 weeks and 6 days. So kahit past 34 weeks, minsan nagbibigay pa rin kami for this minimal benefit. No? But ang nasa book talaga, up to 34, strict about it. So we give this to accelerate your fetal lung maturity. Why? Because your glucocorticoids stimulate the production of your surfactant-associated proteins. So sa pneumocytes mo, alin yung nagpo-produce ng surfactants? It's your pneumocyte type 2. Diba? Yung si type 2 siya yung nagpo-produce ng surfactants. So, ang ginagawa ni corticosteroids, ini-increase niya yung production nitong mga surfactant-associated proteins. That's why it hastens your fetal lung maturity. So these are the two common steroid therapy drugs that we use, dexamethasone and betamethasone. Ang mas mahal dito si betamethasone. Si dexamethasone, it's given 6 milligrams IM every 12 hours for 4 doses. So si betamethasone, ita-twice mo lang yung dose, 12 milligrams, Q24 times 2 doses. So, between the two of them, same lang yung efficacy. However, syempre, kung mas nagmamadali ka at mas may money naman si patient, kasi nga mas mahal si betamethasone, you can give your betamethasone instead of dexamethasone. Ang mas readily available, syempre ito mas mura, no? Si dexamethasone. Yan. So, pero 48 hours yung full course niya instead of just 24 hours. Okay, let's go to case 2 under OB complications. You have an 18-year-old pregravid. She's only 28 weeks AOG, cephalic in preterm labor with ruptured bag of waters. She has irregular contractions on IE, 4 cms dilated na siya. 50% effaced with egress of clear amniotic fluid on speculum examination. No? So ito na talaga, nag-rupture na talaga yung bag of waters niya. Now my question, okay, so give at least 3 medications that you will start in this patient during admission. So may 3 ka na, at give me at least 3. So first, I would give this patient steroids because she's preterm. I would give her magnesium sulfate for neuroprotection. So this is for the prevention of your cerebral palsy. I will give tocolytics. So note na may asterisk ako dyan. Mamaya babalikan natin yan. And I will also give antibiotics kasi nag-rupture na yung membranes mo eh. So meron ka ng connection from the uterus to the outside environment. So she's also a case of PPROM because she's preterm, less than 37 weeks, premature rupture of membrane. So that's your PPROM. So ito yung mga ibibigay ko kay patient na drugs. So let's start with your steroid therapy. So na-discuss ko na to kanina dun sa pre-eclampsia patient natin. Pero may ganito ka sa history, no? Upon further history taking, you learn that she was given dexamethasone at 26 weeks. So 2 weeks ago, nabigyan na daw siya kasi 28 weeks si patient due to threatened preterm labor. Will you still give another 4 doses of steroids? So what's your answer? If I were the attending physician of this patient, yes, I would give another 4 doses of steroid therapy or at least attempt to give 4 doses. Kasi baka mamaya hindi mo naman makomplete lalo na kapag nag-labor talaga, nag-go into active preterm labor si patient. So that's what you call your rescue therapy, okay? So when do you give your rescue therapy? You give this when your delivery becomes imminent and more than 7 days have elapsed since the initial dose. So since si patient 2 weeks ago na yung first course niya ng steroid therapy, we give her another course of steroid therapy kung kaya. Okay? Ayan. Now, we also gave her magnesium sulfate. So, same lang halos yung dosing niya for IV infusion na maintenance, no? So, bakit naman nagbibigay ng magnesium sulfate sa preterm patients? They noted kasi na yung mga very low birth weight na neonates, ng mga mothers who were given magnesium sulfate either for preterm labor or pre-eclampsia, na-note nila na there is decreased incidence of cerebral palsy at 3 years of age. Kaya naisip nila, siguro magandang i-investigate if may effect ba siya, protective effect siya against cerebral palsy. So they noted na true enough, merong benefit nga ang magnesium sulfate in the preterm period through this trial, no, yung BEAM trial. So they tested about 2,000 plus na patients between 24 to 31 weeks. They were given magnesium sulfate 6 grams IV, then 2 grams per hour IV infusion in the next 24 or 12 hours. And they noted na nakaka-decrease nga siya ng cerebral palsy. Now, ang nasa Williams, 24 to 28 weeks lang yung binibigyan ng magnesium sulfate for neuroprotection. But some studies do state na 31 or even 32 weeks may benefit pa yung magnesium sulfate for neuroprotection. So we give this to prevent your cerebral palsy. No? So kumbaga, naging incidental finding siya. So remember kasi, di ba, your magnesium sulfate, it decreases your neurotransmitters or its effects on the receptors. That's why it becomes neuroprotective to your preterm babies. Now, the other thing that you will give your patient is tocolytics. Okay? So let me note na ang tocolytics talaga, kung babasahin mo yung book, it's really just to allow completion of your steroid therapy. No? So ang benefit niya talaga, ang maximum benefit niya is between the 24 to 48 hours na magbibigay ka ng either betamethasone or dexamethasone. Okay? Yun lang talaga yung pinaka-benefit na tocolytics mo. So basically, your tocolytics, ang ginagawa niya is uterine relaxation, okay? To prevent the progression of your preterm labor. So ano yung mga example ng mga tocolytics natin? The first is beta-adrenergic receptor agonist. So example doon is sitabuterin saka si isoxaprine. So remember, si beta-2, kayo na. So relax ka na. So si beta-2 makikita sa smooth muscles like your uterus, no? So it relaxes your uterus. So if agonist ka ng beta-2, you cause uterine muscle relaxation. So you prevent the progression of preterm labor. So another drug that causes decrease in your uterine contractions are your prostaglandin inhibitors. So example dyan, si endomethacin. Remember your prostaglandins, it causes uterine contractions, no? So bakit si endomethacin hindi nyo siya madalas marinig na ginagamit sa mga nagpe-preterm labor? Una, si endomethacin, 24 to 48 hours lang yung kanyang effect, no? Ay, no, sorry. Ulit. So si endomethacin, bakit hindi nyo siya masyadong naririnig na ginagamit? Marami kasing side effects si endomethacin, no? That is the reason why limited yung use niya, maximum 48 hours lang. In some literature, 24 hours lang. Why? Because your endomethacin, because it causes nga contraction, it may cause constriction, vasoconstriction, leading to oligohydramnios. So meaning, binabasoconstrict niya yung renal vasculature, hindi nakakaihi si baby, there is oligohydramnios. It can also cause necrotizing enterocolitis kasi nag-i-ischemia yung GI tract ng babies. And, di ba, remember si endomethacin, this is what they use to medically close your patent ductus arteriosus. Therefore, you potentially run the risk of premature closure of your ductus arteriosus. Dapat, di ba, si ductus arteriosus, di ba, pagkapanganak, saka lang siya mag-close. Pero kapag binigay mo siya in utero, pwedeng mag-prematurely close yung ductus arteriosus ni baby. So we don't want that. Another drug na pwedeng maka-cause ng uterine relaxation is your calcium channel blockers. Obviously, this prevents the influx of your calcium intracellularly. And ito, medyo mas fancy and hindi pa to readily available locally, oxytocin receptor antagonist. So as you can imagine, because it blocks your oxytocin receptors, it will produce uterine relaxation. Okay? Ayan. So sa PPROM, ito depende siya, yung management mo ay depende sa EOG ng patient. Note na kapag 34 weeks or more, classically, we would already induce the patient. Kasi at 34 weeks, more or less, alam mo na mature na yung lungs ng baby. Kaya nga, di ba, beyond 34 weeks, hindi naman na talaga super-duper required na magbigay ng steroids. So for them, pwede ka na mag-labor induction. However, bakit ito naka-red? In the latest ACOG guidelines on PPROM, meron na daw room for expectant management. Okay, so you may offer expectant management for the patient, but labor induction for those na PPROM at 34 weeks or above, yun yung mas preferred ng most OBGYN. Alright? So, bakit ko to ni-note si expectant management? Kasi expectant management na for less than 34 weeks, no? So most of them i-expectant management mo lang. Kumbaga, hindi mo naman papaanakin. Kung mag-progress, edi magpo-progress. Kung hindi mag-progress, edi better for the patient kasi preterm pa lang siya. Okay? So ito, kaya ko to highlight kasi yung index case natin, 28 weeks. Okay? So you do expectant management in these cases. You give your group B strep prophylaxis kasi ito yung most common na etiologic agent, no? That can cause uterine infection that will progress to PPROM. So ano ba yung mga binibigay mo usually for GBS prophylaxis? Usually yung mga ampicillin, ganyan. Kasi penicillin sila, di ba? Gram-positive yung kanilang activity. Single-use corticosteroid course, so that's 4 doses of dexamethasone or 2 doses of betamethasone. Tocolytics, no consensus. Kaya siya naka-asterisk kanina. Although, we tend to give this so that your patient can hopefully, at least man lang, makakomplete siya ng full course niya ng corticosteroids. You also give your antimicrobials and you also give your magnesium sulfate for neuroprotection. Okay? So lahat ng to na-discuss natin kanina. So now let's move on to the drugs that are commonly used in the labor room. So case 1, we have a 28-year-old pre-gravid with gestational hypertension admitted for induction of labor. So most likely 37 weeks to see patient or at least 37 weeks. CST negative. So CST negative, good or bad? So this is good. It means that negative ka for uteroplacental insufficiency. So this is good. So pwede siya mag-proceed with labor. Her Bishop score is only 2 on admission. So unfavorable yung cervix mo. So ang plan mo is to admit the patient, you'll do cervical ripening first before you start your oxytocin drip. No? So you only start your oxytocin drip once the cervix is favorable. So you do cervical ripening. So what are your pharmacological techniques for cervical ripening? You usually use your prostaglandin analogs, no? Either prostaglandin E2 or E1. So si E2 si dinoprostone, si E1 si misoprostol, which is illegal in the Philippines, no? So ang mnemonic ko dito, ito ang gagamitin, E1 nyo na yung bawal. Okay? So E1, iwan mo na yan. Kasi bawal yan. Makukulong ka kapag may misoprostol ka dito. Okay? Pag nahulihan ka. So ito, prostaglandin E2, dinoprostone yung gagamitin natin for cervical ripening. So may 2 forms usually yung dinoprostone. It's either a 10 milligram insert, so parang siyang ribbon, na you leave in the posterior fornix, so below your cervix, up to 12 hours. So after 12 hours, tatanggalin mo siya, you wait 30 minutes, and then you may start your oxytocin infusion kapag okay ka na dun sa cervix mo, no? Pag maganda na yung Bishop score niya. Meron din namang 0.5 milligram per 2 ml na gel. Ito ipapasok mo talaga sa loob ng cervix mo, tapos i-insert mo siya. No? So you can give this every 6 hours for a maximum of 3 doses. No? And then you can give your oxytocin if at least 6 hours na yung nag-elapse since your last dinoprostone dose. Okay? So kung halimbawa nag-insert ako ng 12 noon, 6 p.m. and beyond pa ako pwedeng mag-start ng oxytocin. So what do you watch out for kapag nagbigay ka ng dinoprostone? So dinoprostone, being a prostaglandin, it causes uterine contractions. So aside from uterine contractions kasi, it also restructures your cervix. No? Kaya siya nakakakos ng cervical ripening. So i-ripen nga yung cervix, but at the same time, it may also cause uterine contractions. So isa sa mga side effects ng prostaglandin analogs is tachysystole. So tachysystole, ang definition niya is more than 5 contractions in 10 minutes. No? So remember, every time that your uterus contracts, you are depriving oxygen to your baby. No? Kasi nagbabasoconstrict yan eh. So it could eventually lead to non-reassuring fetal status. So isa to sa mga wina-watch out for natin when you do cervical ripening using your dinoprostone. Alright? So let's move on. So the patient in the previous number, yung dinoprostone mo plus oxytocin, she delivered via outlet forceps extraction. Remember, hypertensive si patient. So assisted vaginal delivery yung ginawa mo. So she delivered after 3 doses of dinoprostone and after 8 hours of oxytocin drip. So matagal to kasi 3 times 6 hours plus 8 hours naka-oxy drip ka. So prolonged labor. So postpartum, she was seen pale, tachycardic with a heart rate of at least 120s. Uterus is not contracted. There is passage of blood clots with fully soaked underpants. So you are dealing with a case of postpartum hemorrhage. Now, yung mga cases of hemorrhage, you may divide that into either postpartum or antepartum. So obviously, si mga after labor, that's postpartum hemorrhage. Ililabel mo siya as early if it happens within the first 24 hours, okay? After delivery. Late kapag beyond 24 hours, usually up to 6 weeks. Some books, 12 weeks, no? Basta beyond 24 hours, that's already considered late. So si patient, since postpartum lang siya, nasa recovery room, early postpartum hemorrhage pa yung kanya. Ang usual culprit mo are one of these 4 T's. Okay? 4 T's, tone, so uterine atony, means ibig sabihin hindi nagpo-contact yung uterus mo postpartum. Tissue, you have retained products of conception, RPOC, retained products of conception. Trauma, pwedeng may lacerations ka in your genital area or your cervix, pwede rin. Or meron kang hematoma. Or the last T is thrombin. Pwedeng meron talaga siyang underlying blood dyscrasia, kaya siya nag-bleed postpartum. No? So si patient, meron siyang problem sa tone. So ito rin yung pinaka-common na cause ng postpartum hemorrhage, your uterine atony. So paano nagkaka-uterine atony? Essentially, ang pagod na matres, postpartum, hindi yan magko-contract, sila yung mga nagbi-bleed. So mga examples mo nun, kapag meron kang malaking uterus, no? So imagine from a well-distended uterus, postpartum, mahihirapan na yan mag-contract, that's why they bleed. So multiple gestation, macrosomic baby, polyhydramnios, kapag may ganun yung patient mo, watch out for postpartum hemorrhage, okay? Sa patient natin, ito yung kanyang risk factor. She has prolonged labor. So in-induce mo pa kasing labor niya. So pagod na talaga yung matres after niyang manganak. That's her risk factor for uterine atony. So what do we usually give? So number one, syempre, is oxytocin. So this is the hormone that is responsible for your contractions during labor. So siya din naman postpartum. So you may give your oxytocin, that is the first line. You may also give your methyl ergonovin, this is your methergin, no? Or your carbopros. So both of these they cause vasoconstriction, no? So they cause vasoconstriction, which leads to uterine contraction. This is also the reason kung bakit hindi mo binibigay si methergin and carbopros sa mga patients mo na may hika, okay? Ayaw mo siyang bigay sa may hika because it will further constrict your bronchioles. So mas lalo silang mahirapan huminga kung in case mag-exacerbate sila. Also, we don't give them to hypertensive patients. Why? Kasi lalo mong i-exacerbate yung high blood. Okay? So si carbetocin, this is an oxytocin analog. So mas mahal siya, mas social siya na form ni oxytocin. So imagine niyo guys, si carbetocin around 1,500 to 2,000 yan versus your oxytocin na libre sa libo rumbo. So yung carbetocin naman, ang benefit nito versus your oxytocin, si oxytocin kasi nilalagay mo siya either IM or via infusion. So marami kang ini-infuse na fluid when you give your oxytocin versus carbetocin na very highly effective, tapos 100 micrograms lang kasi to eh. So pag halimbawa ayaw mo mag-overload ng fluid sa patient mo, pwede kang magbigay ng carbetocin. So example, meron kang gravidocardiac patient or a patient with heart disease, we tend to give them carbetocin instead of your oxytocin. Okay? So sa patient natin, since may gestational hypertension siya, di mo na ibibigay itong mga vasoconstricting agents na to. Alright, so that is the end of pharmacology in obstetrics. We'll now move on to the next subject. So sa pathology naman, magfo-focus ako sa gynae, no? Kasi ito naman yung typically nagiging cause ng surgical na procedures namin. Sa gynae naman talaga. So ito yung mga may high yield topics in pathology. So dalawa lang yan guys usually. Dalawa lang ang usual reasons ba't na-operahan yung patients na gynae. Structural causes of abnormal uterine bleeding and your ovarian masses. So let's start with your structural causes of AUB. So remember the palm coin mnemonic, no? So PAM corresponds to your structural causes, meaning ito yung mga diagnosis via imaging or via histopathology. That is why ito yung i-discuss ko. So isa-isahin natin yung components ng PAM coin starting with AUBP or your polyp. So your polyps, they are overgrowths of your glands, stroma with vessels, no? Covered with epithelium. So since patho to, magpo-focus tayo syempre dun sa patho. Pero i-review pa rin natin, no? Ito yung itsura niya usually on ultrasound. Doktora, hawig niya yung submucosal myoma. I agree. Yun yung mga nakakalito, no? Yung submucosal myoma versus polyp. Ang marker nyo lang, guys, si polyp, since overgrowth siya ng endometrium, it's isoechoic or yung echoes niya, meaning yung brightness niya, is kaparehas ng endometrium mo. Whereas si myomas, usually hypoechoic yan, mas gray yan usually, or mas comparable siya, mas isoechoic siya dun sa myometrium. So ito, sure ka na polyp kasi kasing bright niya or kasing hyper-echoic niya yung endometrium. You see this? So ito siya grossly, no? They are smooth outgrowths in your endometrium, in your endometrial cavity. So smooth lang siya, polypoid, finger-like projections in your endometrial cavity. And on histology, ganito siya. So ito yung four usual components ng endometrial polyp mo. You see your cystically dilated glands. So yan. Yan yung mga glands. You see weakly proliferative epithelium. Usually weakly proliferative na epithelium yan. And ito, yung number 4, that's your fibrous stroma. And you see this, meron siyang thickened arteries. So yung tatlo lang, itong tatlo usually na yan eh, yung makikita mo sa polyp. The glands, the vessels, and the stroma. Okay? So yan yung usual na makikita mo on histology ng polyp. So technically, para lang din talaga siyang endometrium, except cystically dilated yung mga glands. Tapos, syempre, it is from the outgrowth, no? From the finger-like projections into the endometrial cavity. Okay? So, ano daw yung hormone na responsible for polyp? Most of the time, ang culprit mo dyan is your estrogen, okay? Rather than your polyp. Rather than your progesterone. So, si estrogen daw yung nagsistimulate ng growth ng iyong polyp. Okay, so let's move on to A, adenomyosis. So, ano ba si adenomyosis? Your adenomyosis is the presence of endometrial glands and stroma in your uterine myometrium, no? So look at this picture, no? So meron siyang glands and stroma ng endometrium embedded within your myometrium. So dapat at least 1 LPF or 1 low-powered field siya, or at least 2.5 millimeters from the basalis layer or the deepest layer of your endometrium. So ano yung mga nagiging chief complaints again ng mga patients na may adenomyosis? Dysmenorrhea, heavy bleeding, and diffusely enlarged uterine corpus. Why? Dysmenorrhea kasi, di ba, every time nagre-regla sila, nagre-regla din tong glands na nasa loob ng myometrium. That's why they present with dysmenorrhea. So nagpo-produce yun kasi ng prostaglandin. That's why it's very painful. Also, heavy menstrual bleeding kasi because of the aberrant presence of your glands and stroma in the myometrium, meron ding abnormal uterine contraction yung uterus. So hindi siya nakaka-contract well, therefore nagbi-bleed lang siya ng nagbi-bleed. Diffusely enlarged kasi the presence of the glands and your stroma in your myometrium causes hypertrophy of the muscles that surround them. Alright? So ito siya on imaging. Ang mas importante right now is alam nyo siya grossly, no? Ito yung gross specimen ng mga patients who underwent hysterectomy for adenomyosis. As you can see, no, thickened yung muscle walls nila. And aside from being thickened, globularly enlarged, meron silang asymmetry. So minsan mas makapal si anterior more than your posterior, or pwede rin namang baliktad, no? Although mas common na si anterior yung mas makapal compared kay posterior. So mapapansin nyo, no, may mga ill-defined whorls, W-H-O-R-L, whorls of glands here within your myometrium. So sometimes, gaya nitong sa specimen na to, may mga petechiae, no? So ibig sabihin, nagme-mens to during the time na hysterectomy siya. So nagbi-bleed din kasi itong mga glands na to. They're also hormonally responsive. Yan. So this is a very good picture of adenomyosis. So you can see here, nakikita nyo itong mga circles na to, mga irregularly shaped ovals na yan. These are your glands, no? So kung halimbawa yung endometrium lang yung ibabiopsy mo, ganito yung typical picture niya, no? Ganyan yung mga nakikita nyong circles na yan. These are the glands. Ang problem dito kay patient, tong glands na to wala sa endometrium. Instead, it's embedded within the myometrium. You see this? Ito yung these long fascicles of cells. These are your myometrial cells, okay? That's your myometrial tissue. So, dun siya naka-embed. So, that's your adenomyosis. Now, we move on to L. So, this L, ito very common to, no? Your leiomyoma. So, these are benign tumors of smooth muscle cells, no? So, tandaan nyo tong cells na to, itong itsura na to, kasi halos ganyan din yung itsura ni leiomyoma. Kasi yun yung kanyang etiology. They come from benign tumors of smooth muscle origin. So they present with heavy menstrual bleeding, enlarged corpus with irregular contour kasi iba-iba, very variable yung location ng myoma mo. Heavy menstrual bleeding, especially when it causes abnormalities in uterine contraction, so hindi nagko-contract, mas nagbi-bleed. Also, if it distorts your endometrium, no? So, the distortion in the endometrium causes your heavy bleeding. Kaya yung mga submucosal myoma, yan ang notorious for causing AUB in patients with AUBM. So, ganito siya on ultrasound. Kung papansinin nyo, no, hypoechoic siya, mas gray siya compared dun sa the rest ng uterus mo. So, di ba si polyp, bright siya, hyperechoic. So, ganito siya guys on gross specimen. So, very classic. Hindi nyo makakalimutan yung itsura ng myoma once you see one. So, grossly, pag pinadescribe sa'yo ng resident, so describe the specimen to us, Doktora. You see a well-circumscribed guys ha, pero hindi siya encapsulated. Walang true capsule ang myoma. Meron siyang pseudo-capsule kasi yung surrounding myometrium niya para siyang nag-form ng capsule around the myoma. But technically, in itself, wala talaga siyang capsule. So it's well-circumscribed na solid mass. It has a pearly white surface. No? And ang classic descriptions are LED, world pattern. So it has a classic world pattern, no? So pearly white or white to tan, yun yung mga description ng color ng myoma. So on histology, you will see here na meron siyang mga interconnecting na fascicles, no? So parang kahawig niya yung kanina, 'di ba, na myometrium, no? Pero ganyan siya. Meron siyang ganyan yung itsura niya on histology. So yung mga benign, yung mga myomas, most of the time benign yan. Meron din kasi siyang malignant na counterpart which is leiomyosarcoma naman. So iba yung itsura nun. Pero kapag benign looking lang siya, uniform yan ng mga fascicles ng muscle cells. Ang muscle cells na dikit-dikit, no? Yung itsura niya on histology. Okay, so meron tayong tinatawag na degeneration of myomas. So paano nagkakaroon ng degeneration of myomas? So the degeneration happens when the myoma is too large such that na overgrow na niya yung vascular supply niya. Kaya nagkakaroon ng degeneration. So hindi ko na iisa-isahin guys itong mga kinds ng degeneration of myomas. But what's important to note is this one, no? Si red or carneous degeneration, because this is the one that is most common in pregnancy. So how does this happen? Nagkakaroon ng ischemia, no? Nagkaka-infarct. Nagkakaroon ng microinfarct dun sa vasculature ng myoma mo, causing this red or carneous degeneration. So if you have a patient na may history ng myoma before pregnancy and during the pregnancy, bigla siya nag-present with acute abdomen, isa to sa mga isipin mo. She must be having red or carneous degeneration of her myoma. Naget? Okay, so let's move on to AUBM. So this is your last in your palm coin, no? Last structural cause under the FIGO classification. So AUBM stands for malignancy. M stands for malignancy here. So it corresponds to your endometrial malignancy or endometrial cancer, or it could be endometrial hyperplasia. So your hyperplasia being a pre-malignant lesion, considered na siya under AUBM. Naget? So hindi siya AUBE ha, hindi siya under endometrial cause, AUBM ang hyperplasia. So ang main culprit mo for endometrial cancer or hyperplasia is unopposed estrogen. So when you have unopposed estrogen, kapal lang ng kapal yung endometrial lining mo. That is why prone siya mag-transform into hyperplastic changes which could eventually become cancer. Okay? So ano yung presentation nila? They usually present with prolonged menses or heavy menstrual bleeding. And on imaging, they present with thickened endometrium. Okay? Gaya nitong sa patient, thickened endometrium with or without myometrial invasion. Pag with myometrial invasion ka na, you'll think more of endometrial cancer rather than hyperplasia. Okay? So review lang natin ulit yung menstrual cycle, no? So hindi ko na isa-isahin yung phases ng menstrual cycle, but ang important malaman at this point is itong endometrial phase. So endometrial phase, which is proliferative phase, so that's your first half of your menstrual cycle. So the second half is your secretory phase. So secretory phase happens after ovulation. Okay? Si proliferative phase, primarily, ang nagproduce ng effects ng proliferative endometrium is your estrogen hormone. Sa secretory, it's your progesterone. Okay? So review natin muna yung normal endometrium bago tayo magpunta dun sa abnormal na endometrium. So sa proliferative, again, ano yung hormone na responsible for the first half of your menstrual cycle? It's your estrogen. So sa proliferative, by the name itself, nagpo-proliferate pa lang yung glands and stroma mo. So papansinin nyo, ito yung mga glands, this is your stroma, mas marami yan during your proliferative phase. Now, your secretory phase, which happens after ovulation, pwede mo pa siyang i-divide further into 3 phases. Early secretory is 2 to 4 days post-ovulation. Mid-secretory is 5 to 9 days. Late secretory is 10 to 14 days. Ang important na nangyayari kay secretory phase, by the name itself, nagkakaroon na secretions yung mga glands na nag-proliferate during the proliferative phase. That's why nagkikink na sila like that. Okay? So, yan yung proliferative phase. Kung papansinin nyo din, di ba, para nang merong laman tong mga, may laman ng white yung mga cells niya, no? Yung mga glandular cells, yung nagla-line around the cells. So, syempre, nagdadilate na sila during the mid-secretory. And during the late secretory phase, makikita mo, no, very dilated na yung mga vessels and marami ng secretions yung mga glands. So pag tinanong kayo, ano yung first sign ng secretory phase, it is your subnuclear vacuoles or your secretions subnuclear. Mamaya papakita ko rin yan sa picture ko. So this is the first sign of your secretory phase. So kung yung mga glands mo may at least 50% na may subnuclear vacuoles, then it means na nasa secretory phase ka na. Pumasok ka na ng secretory phase. So ito, mas makikita nyo dito sa next picture. Yung pinupoint niya dito si subnuclear vacuoles. No? So parang may laman na siya under the cells, di ba? So ito yung nucleus, so kaya siya subnuclear, under the nucleus, makikita nyo na yung secretions ng glands nyo. Yan, di ba? Very maganda yung itsura niya. Ayan, meron na siyang glandular secretions na makikita nyo subnuclear. Ayan. Okay. So, eventually, pwede kapag meron kang unopposed estrogen, pwedeng kang magkaroon ng hyperplastic changes. So makikita nyo, di ba? Titingnan nyo, parang back-to-back na tong mga glands nyo. Una sa lahat, mataas yung gland to stroma ratio mo. So mas maraming glands kaysa sa stroma, back-to-back na siya. So ito yung mga hyperplasia. So ito yung mga hyperplastic changes na tinatawag. Now, ang hyperplasia, it could be divided into 2, without atypia and with atypia. So ano yung tinitingnan mo to say na meron siyang with atypia or without atypia? Ang titingnan nyo guys, ito, I'm not a pathologist, but the way I interpret the pictures, no? I look at the nucleus of your patients. Okay? So kung papansinin nyo itong nucleus nito, parang pencil-like pa. Alright? Nakikita nyo siya, pencil-like. Tapos nasa base pa yung nucleus mo. Nasa base siya, tapos pencil-like pa yung itsura ng nucleus mo. Then wala siyang atypia. Pag may atypia ka kasi, labo-labo na yan, no? It could appear anywhere within the nucleus. Hindi na lang siya sa base. Like this, di ba? Ito, makikita mo, nasa base pa siya nung cell. Ayan. Pero itong without atypia, kahit saan-saan na lang siya, labo-labo na lang siya within the cell. Plus, take note of the uterus. This one, pencil-like, na very dense yung itsura. Whereas here, makikita nyo, no, hindi dense, tapos ovoid na, mas oval na yung nucleus mo. When you see that your nucleus is like that, labo-labo na, wala in a single pole, wala dun sa iisang pole. Like this, so tingnan nyo to, isang pole lang siya, isang pole lang sila. Tapos hindi na sila pencil-like, ovoid na. Tapos hindi na dense yung chromatin within, that is a patient with atypia. Okay? That is a tissue with endometrial hyperplasia with atypia. Okay. Quick quiz. We have a 40-year-old, multigravid, dysmenorrhea yung chief complaint. This is your histologic picture. Give me your diagnosis. So this is adenomyosis, no? Kasi endometrial glands and stroma within your myometrium. So this is adenomyosis. Next question. 20-year-old, naligavid with PCOS. So mataas ang estrogen nito. Hindi parating nag-ovulate. So estrogen responsive na tumor, na meron kang dilated cyst with stroma, vessels, and endometrium na usually weakly proliferative. Ito ay endometrial polyp. Next question. Which myomatous degeneration, wrong spelling, anyway, degeneration most commonly occurs during pregnancy? It's this one, no? Red or carneus degeneration. Okay. So which picture has atypia? So alin yung mas ovoid, walang polarity, yung nucleus, tapos hindi kasing dense yung nucleus, no? So ito medyo may atypical features na rin siya, but between the two of them, itong isa yung mas i-commit mo na may atypia. Kasi at least ito meron pang polarity, yung nucleus mo nasa baba pa yan lahat, tapos hindi pa ganun ka-ovoid, no? Somehow medyo dense pa rin yung chromatin within compared dito. Alright? So ito yung may atypia. The picture on the left. Alright? Okay, now we move on to the pathology of your ovarian masses. So ito kasi yung isa pa sa mga reasons kung ba't na-operahan yung patients natin. Okay, question, nababalikan din natin mamaya if you can. So you can take a screenshot of this, you can quiz yourself. Alin dito yung histologic finding that corresponds to each ovarian tumor? Saan makikita si Kahl-Exner, Schiller-Duval, signet ring, saka si thyroid follicles? So alin sila dito? Okay, so balikan natin yung question na yan later with pictures. So remember guys, yung mga kinds ng ovarian tumors, it depends on the part from which it was derived from. So meron kang epithelial tumor. So coming from your germinal epithelium. Yan, epithelium. Okay. So si germ cell tumors comes from your germ cell. So si germ cell tumors, sila yung mga later on nagiging embryo or yung mga extra-embryonic tissue. Extra-embryonic like your yolk sac, placenta, yun yung extra-embryonic. Si embryo is your baby. Yan. So sino yung mga yon? Galing sila sa oocytes natin. So si sex cord are your follicles, no? Si granulosa cell, yan. Si theca cells, yan. Yan yung mga, dyan nag-a-arise yung sex cord tumors. Si stroma, ito yung mga, so syempre mga galing sa stroma. And then there are also tumors that come from other primaries such as your metastatic tumors, specifically the one from your GI tract na mamaya i-discuss natin. So isa-isahin natin sila. So the most frequent tumors are your epithelial tumors. So maraming kinds ng epithelial tumors, guys. Depende kung sino yung kamukha nila na cell. Si serous, kamukha niya si fallopian tube. Okay? Remember guys, ngayon nagpo-prophylactic salpingectomy na kami sa mga patients. So instead of just doing tubal ligation, buong tube na yung tinatanggal namin, this is what we're trying to prevent, no? Yung mga serous carcinomas of the ovarian, of the ovaries. Okay? So they are prophylactic against these kinds of tumors. Si mucinous naman, syempre, ang kahawig niya, yung mga mucin-producing cells like your endocervical or intestinal cells. Endometrioid and clear cell, these are both associated with your endometriosis. Brenner cell, it resembles your uroepithelium or the epithelium of your bladder. Okay, so ito yung mga grossly, napakita ko na to sa inyo before, no? Ito ay example ng serous tumor. Mucinous, ba't ko alam na mucinous to? Kasi look, meron siyang gelatinous na fluid within its surface, no? So yan yung glistening na yan yung mucin that it produces. This one is clear cell. So obvious naman kung ba't siya clear cell, no? Because it has clearing within its cytoplasm. And now let's go to the high-yield pathology concepts in these tumors. Sa MoMA body, saan mo siya makikita? Makikita mo to sa serous cystadenocarcinoma of the ovary. Now, I did not ask this kasi it's not pathognomonic to your serous cystadenocarcinoma of the ovary. You can also see this in papillary thyroid CA, meningiomas, and in other cancers, no? So ano ba yung sa MoMA bodies? So mga calcified structures yan, lamellated structures like this one. So mga calcification yan na makikita mo within the tumor. So that's your samoma body. So pag samoma bodies, that's another buzzword. If you're talking gyne tumors, serous yung you're dealing with a serous tumor, serous cystadenocarcinoma. Okay, so pakita ko lang sa inyo yung benign versus malignant. So when you see benign, single layer lang yan ng epithelium usually. Pero pag nakita nyo naman pag serous, back-to-back na, wala ka na halos stroma. And look, the nucleus look very atypical, no? In malignant serous. So yan yung parang isa sa mga typical histologic pictures ng serous versus na malignant versus benign. Now, si mucinous, alam mo na mucinous siya because papansinin nyo guys, yung sa ilalim na sa ilalim. Basically, okay, mali yung term na sa ilalim, but beside your nucleus, meron nandyan yung mga glandular secretions niya, no? So parang may laman yung cells niya. So kaya siya mucinous, no? Kasi alam mo na nasa loob niyan are mucinous fluid. Okay? So ganyan yung itsura ng benign. So may polarity yung nucleus, dense yung nucleus, tapos single layer lang siya. Compared to this one, no? Very atypical looking, yung ovoid na yung nucleus niya, back-to-back na yung configuration ng mga glands. So alam mo na, labo-labo na to. So this is a good picture of malignant versus benign mucinous. Okay? So nag-get? So pag napakitaan kayo ng picture na mukhang may laman na mucin sa loob ng cell, alam mo na na mucinous tumor yan. Titingnan mo na lang kung benign versus malignant. Si malignant, mas marami yung glands versus the stroma. Back-to-back na siya. And then if you look at ang tingnan nyo talaga dito guys, yung nucleus. Kung papansinin nyo, no, ovoid na siya. Tapos wala ng polarity. And then hindi na dense sa loob ng nucleus. Hindi na siya black na black like this one. No? So that's this is a picture of a malignant mucinous tumor of the ovary. Now, si clear cell carcinoma, I'm sharing with you another buzzword, si hobnail cells. So ito yung hobnails, sometimes yung mga books, they describe it itong, as in nasa hobnail siya nung sole ng shoes, no? Ba't siya hobnails? Ano ba yung kina-hobnail niya? Kung papansinin nyo, sa clear cell carcinoma, yung nucleus niya, para na siyang ini-extrude out of the cell. Para na siyang niluluwa ng cell. Yun yung tinatawag na hobnailing, okay? Yan yung mga hobnail cells. So this is a typical picture of your clear cell carcinoma. Pag nakita nyo na mukhang niluluwa na ng cell, yung nucleus niya, hobnail cells, think clear cell carcinoma. Now, we don't like this kind of carcinoma because this is very aggressive, no? Very poor prognosis for patients pag meron silang clear cell carcinoma. Next kind of epithelial tumor is your Brenner tumor. Your Brenner tumor could either be malignant or benign. Now, si Brenner tumor, para yung islands of cells, no, within the stroma ng ovaries mo. And when you zoom that in, you will see this classic look of its nucleus, no? Mukha siyang coffee beans, okay? So take note na si Brenner tumor, hindi lang siya yung may coffee bean nuclei. Later on sa discussion, malalaman nyo yung isa pang may coffee bean nuclei. Pero that's one of the buzzwords for Brenner tumor, coffee bean nuclei. Plus, yung mas telling na Brenner tumor siya is that it resembles your uroepithelium or the epithelium of your urinary bladder. Okay? Sige. Let's move on to your germ cell tumor. So this is another family of ovarian tumors derived from the germ cells. This is the second most frequent ovarian neoplasm. So ito yung mga usual tumors na may homologous counterparts sa males. So the most common is your dysgerminoma, no? Ang homolog niya sa males is your testicular seminoma. Remember, its tumor marker is your LDH, no? So this is the most common malignant germ cell tumor. So kapag kinot mo siya on gross specimen, solid lang siya, solid na irregular yung surface. And then on histology, parang lymphocytic yung itsura niya, no? So homogeneous lang yung itsura niya na lymphocytic, tapos may mga konting stroma. Yan yung germ cell tumor. Ayun yung just dysgerminoma. Yan. Boring yung dysgerminoma, so hindi yan usually yung tinatanong. So yung another malignant germ cell tumor is your immature teratoma. Meron siyang benign counterpart, which is your mature teratoma. Okay, so yung histopathologic grading ng immature teratoma is dependent on the amount of your immature neuroepithelium. So kapag in-ultrasound mo sila, complex yung itsura ng mass. Halo-halong cystic, solid, and then ito siya, very irregular na solid tumor. Yung itsura ng immature teratoma. Usually, ang tumor marker natin for this is your AFP. Now, compare that with this one. No? This is a picture of your mature teratoma. Sa immature teratoma, hindi mo na ma-distinguish yung mga hindi mo na ma-distinguish yung tissue compared to your mature teratoma. Kaya siya mature kasi well-differentiated yung mga ectodermal, mesodermal, endodermal structures niya. No? Usually, makakakita ka dyan ng buong ngipin or ng cartilage or ng hair, okay? Or ng sebum. Ayan, yan yung mga usual na nakikita nyo within your mature teratoma. Okay, so yung histologic picture niya, itong nakapoint na to, these are your immature neuroepithelium. So dyan nagde-depend yung grading ng immature teratoma. Versus your mature teratoma, tingnan nyo naman very well-defined na, no? Well-differentiated na yung mga ectodermal components, endodermal components, mesodermal components. You have here your cartilage, your fat, ano pang na-identify nyo. Ito, mayroon ditong follicles, yan. So, meron siya. So, mature na yung mga structures na nakikita mo or yung mga cells na nakikita mo sa mature teratoma. This is a special type of mature cystic teratoma or teratoma na predominantly thyroid tissue follicles yung itsura niya, no? On histology. And this is your struma ovary, okay? Si struma ovary, this is also hormonally active. So, meron din silang hyperthyroid symptoms most of the time. So, if you have hyperthyroid symptoms like increased FT4 with palpitations, etc., tapos meron siyang ovarian tumor, you can think struma ovary, okay? So, ito ay under ng teratoma, pero ang special sa kanya, mukha siyang thyroid on histology. Okay, so the next type of germ cell tumor is your yolk sac tumor. Okay, so this also secretes your AFP. So medyo hawig sila ni immature teratoma, di ba guys? Pero ano ang classic sa kanya? Meron siyang pathognomonic na pathologic feature, which is your Schiller-Duval bodies. Okay, ito si Schiller-Duval bodies. Si Schiller-Duval is a blood vessel surrounded by your malignant cells, no? So yan si yolk sac tumors. Yan yung Schiller-Duval bodies. So paano ko naaalala si Schiller-Duval bodies na nasa yolk sac tumor? So imagine niyo itong blood vessel na nasa gitna, that's your pula ng itlog, okay? Tapos yung egg whites niya surrounding it, yan yung mga malignant cells. So ito, mukha siyang itlog, mukha siyang sunny side up, yolk sac tumor, Schiller-Duval bodies. Okay? Now, your next family of ovarian tumors are your sex cord stromal tumors. Minsan lumped na sila together kasi konti lang naman yung mga sex cord stromal tumors. So, ang i-discuss ko dito mainly is your granulosa cell tumor kasi ito yung may pathognomonic na histologic picture. Remember, si granulosa cell tumor mo, ito yung hormonally active mo na tumor. It produces estrogen and inhibin. So, si inhibin yung tumor marker mo. In the young, it can produce precocious puberty. Sa reproductive age women, AUB. Kapag postmenopausal bleeding naman yung symptom nila. So, kay granulosa cell tumor, meron siyang pathognomonic na histologic feature, which is your Kahl-Exner bodies. Si Kahl-Exner, ang usual description sa kanya, follicular yung formation niya sa rosette formation. Basically, naka-circle yung mga fluid within. Okay, so that's your Kahl-Exner body. So kung ang gitna ni Schiller-Duval ay blood vessel, ang gitna ni Kahl-Exner ay eosinophilic fluid. Okay? So kung papansinin nyo, kung i-zoom in nyo rin tong nucleus, meron din siya ng coffee bean nuclei. So ano pa yung isang may coffee bean nuclei? It's your uroepithelium-like na tumor, yung Brenner. So si Brenner saka si granulosa cell, they both present with coffee bean nuclei. So mukhang may hati kasi sa gitna yung mga nuclei niya. Ayan. So siya din, may coffee beans din siya. So yan, si granulosa cell tumor. Okay, so we'll go to one kind. Usually si stromal tumor, stechoma lang yan, saka fibroma. Pero let's just focus on fibroma muna. Okay, so ito naman yung most common. Si fibroma, kung papansin niyo, sino yung hawig niya sa palm coin? Hawig niya si myoma. Diba? Hawig niya histologically, pati yung gross picture niya. Sila yung parating na papagkamalan sa isa't isa on ultrasound. So minsan nakala namin subserous na myoma, yung pala fibroma siya. So on cut section, sa gross specimen, pearly white din siya, solid na tumor. Tapos on histology, yan din siya, fascicles din siya, mukha din siyang parang muscle cells, no? So that's your fibroma. Anong unique kay fibroma? Si fibroma may tinatawag na Meiggs syndrome. Si Meiggs syndrome may 3 components siya. Ovarian fibroma, ascites, and because of the ascites na umaakyat to the pleural cavity, meron din silang pleural effusion or hydrothorax. Itong pleural effusion na to, minimal lang naman to usually, unless sobrang massive talaga ng ascites mo. So ovarian fibroma is said to cause the ascites because of the peritoneal irritation, no? Kaya daw siya nag-ascites. So may special name for that, that's your Meiggs syndrome. Now, you may hear this pseudo-Meiggs syndrome. Ano yung pseudo-Meiggs syndrome? Pseudo-Meiggs syndrome, ganun din. May ovarian tumor din siya, may ascites, tapos may pleural effusion. Pero instead of fibroma, malignant yung ovarian tumor mo. Okay? So since hindi siya fibroma, ang Meiggs syndrome, dapat kasi talaga ovarian fibroma siya na benign. Okay? So kapag halimbawa ovarian new growth malignant na may ascites din, because that usually happens, tapos nagkataon din na may pleural effusion, ayun, sometimes we call that clinically as pseudo-Meiggs syndrome. Pero hindi namin sinasama sa diagnosis. We just mentioned this kasi it mimics your Meiggs syndrome, which is a condition with a benign ovarian tumor with these other 2 components ng syndrome. Get? Sige, last na to. So metastatic ovarian tumors typically from your GI tract. So these are what we call your Krukenberg tumors. So dahil metastasis sila, they usually appear bilaterally. Okay? So ang important na maalala nyo sa kanila sa pathology are your signet ring cells. So yung signet ring cells, kaya siya nagiging mukhang signet ring, is your mucin pushes up your nucleus. So mukha siyang signet ring. Okay, so yung mga graduation ring ng parents nyo, or graduation ring nyo, yun yung signet ring, di ba? So, mukhang ganun yung cells ng Krukenberg tumor. So, that's one of the histologic pictures that will point you to a metastatic ovarian rather than a primary ovarian tumor. O yan. Now that we're done discussing these things, punta na tayo ulit dun sa question. Okay? So basically, ginawa ko lang picture form yung mga questions ko kanina. So itong una, ano tong parang rosette formation, no? Follicular formation, yung gitna niya eosinophilic fluid. So this is your Kahl-Exner. ito mukhang sunny side up na egg. So meron kang gitna, pula sa gitna, no? So your blood vessels surrounded by your malignant cells. This one, ano to? So makikita mo no, si nucleus pushed na siya by mucin within the cytoplasm of your cell. So mukhang signet ring. So ito mukhang thyroid follicles. Okay? So tama ba yung mga description natin? So ito si Carl Exner, di ba? So again, ano pa yung important kay Carl Exner? Yung nucleus niya mukhang coffee bean. Sino yung isa pang may coffee bean? Si Brenner. Okay, si Brenner tumor. Si Schiller-Duval bodies, signet ring cells, thyroid follicles. Okay? So si Carl Exner, saan makikita? Sa granulosa cell tumor. Si Schiller-Duval, sino yung itlog? Yolk sac tumor. Signet ring cells, saan siya makikita? Krukenberg tumors. And finally, si thyroid follicles, pag predominantly thyroid follicles siya, it's a type of teratoma. Specifically, it's your struma ovary. Struma ovary, yeah. Isip ko pa yung pronunciation. Alright, so that's the end of your path apart for your gynecology. We'll now move on to microbiology. Ito mabilis na lang yung microbiology. So obviously, ang i-discuss ko dito are your OBGYN infections. Pero we'll focus on the microbiology part. So for this, ang style ko dito will just focus on the buzzwords in OBGYN microbiology. So basically, I will tell you buzz phrases or buzzwords. Tapos, sasabihin nyo kung ano yung diagnosis. Okay? So, thin, milky discharge. Saan siya nakikita? Strawberry cervix, spaghetti and meatballs after KOH application dun sa smear. Clue cells. Saan nakikita yung clue cells? And positive whiff test. So, saan siya nagiging positive? Ano yung disease entity behind this? Okay? So, ito yung mga words or phrases na kapag nabasa nyo dun sa stem ng question nyo sa mga test, ito dapat mag-ring na to sa utak nyo, madadiagnose nyo na sila agad. Okay? So, review muna natin. So, usually, isa sa tatlo lang yung tatlong to yung causes ng vaginal discharge. It's either bacterial vaginosis, trichomoniasis, or your vulvovaginal candidiasis, or your VVC. Okay? Si bacterial vaginosis, ang classic description sa discharge niya, thin, whitish gray, homogeneous, fishy yung odor ng discharge. Si trichomoniasis, yellow frothy discharge with or without vaginal or cervical erythema. Tapos makikita nyo may punctate lesions yung cervix, kaya siya tinatawag na strawberry cervix. Si candidiasis naman, white, thick, curd-like, so parang cottage cheese yung appearance ng discharge niya. Pero ang pinaka-irereklamo sa inyo ng patient, the cardinal symptom of VVC or vulvovaginal candidiasis is pruritus. Sobrang kate. Okay? So ito yung mga treatment options nyo for bacterial vaginosis, trichomoniasis, and candidiasis. So basically sa candidiasis, because it's a fungal infection, your azoles are the ones that you give either topically or orally kung hindi naman buntis si patient. Si bacterial vaginosis sa si trichomoniasis, parehas silang metronidazole. Si bacterial vaginosis, full week mo siya. As in, 1 week mo yan ibibigay twice a day. Si trichomoniasis, single dose lang siya. Pero mataas yung dose niya, 2 grams. Okay? So si bacterial vaginosis, sa kanya mo makikita si clue cells. Okay? Ano ba ibig sabihin ng clue cells? Your clue cells are your epithelial cells studded by bacteria. So ito yung isang example ng clue cell. Alright? So ano pa meron kay bacterial vaginosis? Ito rin yung nagpa-positive whiff test. So when you say positive whiff test, pag nag-drop ka ng KOH, may classic amine odor or fishy odor na mapoproduce. So yun si positive whiff test, which you see in bacterial vaginosis. So si trichomoniasis, ang nagpo-cause ito is your Trichomonas vaginalis. So that's a protozoa na motile. Okay? So yun yung important kay trichomoniasis. Ayan. So flagellated na motile organism yung makikita mo sa trichomoniasis. Sa candidiasis naman, when you put KOH, so ano bang purpose ni KOH? It denatures your proteins. So ang matitira na lang are the hyphae and the spores of your fungi. Siya si meatballs, and your spaghetti. Okay? So, balikan natin si buzzwords. Thin, milky discharge, bacterial vaginosis, strawberry cervix, trichomoniasis, spaghetti and meatballs, saan makikita, ito yung hyphae and spores ng candidiasis, flu cells and positive whiff test, sa BV ulit sila, or bacterial vaginosis. Nagkaka-BV, ano na ako? Confusion. Okay? So let's move on to the next set of buzzwords in OBGYN microbiology. Beefy red ulcer. Okay? Tandaan nyo yung main genesis lecture ko. Saan si beefy red ulcer? Saan yung may school of fish appearance on microscopy? Donovan body, saan siya makikita? So obvious na to kasi Donovan, doon nga na-derive yung name ng disease entity eh. Safety pin appearance, saan makikita si safety pin appearance? Pwede rin bipolar appearing organisms, no? Bipolar kasi yung pins, yun yung poles ng safety pin mo. Silvery spiral organisms on dark field microscopy. Saan to makikita? Okay? Anong disease entity yung may ganito sa diagnostics niya? So review muna natin. So this is one of my favorite slides. So kapag ang pasyente sa'yo dumating, it's either she could be complaining to you of drips. So yung drips, ito yung mga usual causes ng vaginal discharge in your patient. Pwedeng gonorrhea, chlamydia, mucopurulent cervicitis, candidiasis, trichomoniasis. So ito yung mga drips mo. Pag sinabi mong source, these are your ulcers. Now, your ulcers, they could either be painful or painless. Painful, dalawa lang yan. Si herpes or si chancroid or chancroid. Because it's so painful, you cry. Chancroid. Okay? So, dalawa lang yung painful ulcers usually. Sa painless, tatlo yung differentials natin dyan. Syphilis, si LGB, and your granuloma inguinalis. So, isa-isahin natin para marinig natin or ma-review natin yung mga high yield na microbiology points or ideas dito sa mga OBGYN infections na to. So si chancroid, as I mentioned, it's painful. So kaya siya chancroid, okay? So usually may kasama yung tender na lymphadenopathy or your buboes, and it's caused by Haemophilus ducreyi, okay? Ducreyi, okay? Chancroid, ducreyi, yan. So it's a small gram-negative rod. So when you say gram-negative, it means na hindi niya na-absorb yung violet stain, di ba? Si yung gram staining, violet yun. So kapag gram-positive ka, dapat medyo blue yung itsura mo or violaceous. Pag gram-negative, it means na hindi siya nakaka-absorb ng gram stain mo. Si gram stain kasi, di ba, violet siya. So kapag gram-positive siya, ang makikita mo on microscopy, more of violet or more of blue. Pag gram-negative, more on the pink hue, yung itsura niya on microscopy. It forms this classic formation which you call school of fish appearance. Okay? So, ganyan naka-arrange yung bacteria. So, ito yung classic picture ng chancroid ulcer. But what we'll focus on is ano yung itsura niya on microscopy. You see here, itong gram-negative rods na to. So, pink rods na para silang nakapila na fish. Okay? So, ito yung graphical representation niya. So, ito siya on actual microscopy. Pink na rods na nakapila like that, like school of fish. Sometimes, ang tawag sa kanya sa books, railroad tracks. Basta essentially, ganyan yung itsura niya. Para silang mga fish na nakapila. So para mas maalala nyo na yung school of fish is a chancroid, think of a school of crying fish. Okay? School of crying fish, crying, chancroid, chancroid. Okay? So caused by your Haemophilus ducreyi. Okay? Ducreyi. Next is your syphilis. Si syphilis, it causes painless ulcers naman. So syphilis is caused by your Treponema pallidum. It's an anaerobic elongated tightly wound spirochetes. So ganyan siya, para siya yung mga slinkies. Ayan. So it can penetrate the skin or the mucous membrane. No? So ito siya on dark field microscopy. So ang classic description niya on dark field microscopy ay silver na spiral organism. So yan yung si Treponema pallidum. So your Treponema pallidum, ang ano niya, ang kinukos niya is your syphilis. So hindi ko na di-discuss to isa-isa, basta alam nyo na ang syphilis may 3 stages yan. Primary, secondary, tertiary. Si primary is your painless ulcer. Si secondary, systemic. Si tertiary, andyan na yung sa mga mag-i-embed na siya sa mga cardiovascular system mo, sa CNS mo. So mas malala na yung systemic manifestation mo sa tertiary. Okay? So hindi na natin iisa-isahin to since hindi ito yung focus ng lecture na to. So si syphilis ba, nagda-dark field microscopy pa tayo sa kanila? Usually guys, hindi na tayo nagda-dark field microscopy sa syphilis. So this is more for your exams na lang, no? Because in practice, what we do is, to screen for syphilis, we order for VDRL or RPR. So kapag nag-positive yon, hindi ibig sabihin na may syphilis si patient. We move on to your confirmatory test. So ano yung mga examples ng confirmatory test? FTA-ABS or yung mga TPPA, yun yung mga examples mo ng confirmatory. So we don't usually perform dark field microscopy na in practice. So ano na lang to, historical and more of for your information. Alright, so your LGD or your lymphogranuloma venereum, it's caused by the serovars of your Chlamydia trachomatis. Now, ang important kay chlamydia, it's obligate intracellular. Okay, ano ibig sabihin ng obligate intracellular? It means na it requires a host cell for it to live. Therefore, on its own, hindi mo siya madedetect kung magkukulture ka. So kung magkukulture ka, dito yung culture na to, it has to come with a tissue. So talagang magkukuha ka ng part ng tissue because otherwise you will not be able to isolate your Chlamydia trachomatis. So that's your obligate, yan yung implication, yan yung importance ng pagiging obligate intracellular niya. Now, luckily, may iba na tayong ways of diagnosing your lymphogranuloma venereum via direct immunofluorescence ng mga scrapings or via nucleic acid detection. So ito yun na yung mga fancier ways of detecting Chlamydia trachomatis L1, L2, L3. Now, the last that I would want to discuss with you is si granuloma inguinale or donovanosis. Okay? Essentially, guys, ito kasi siya. Ito yung gusto kong i-describe sa inyo na ulcer, no? Beefy red yung ulcer. So, beefy red, that should be a buzzword for your granuloma inguinale or donovanosis. Now, it is caused by your Klebsiella granulomatosis. Okay? May dating name to, si Camelobacterium, ganyan, di ko na maalala. Basta may dati siyang name. Ito na yung newer name niya, Klebsiella granulomatosis. Okay? On microscopy using silver stain, it will have Donovan bodies, which are clusters of dark staining bacteria with a bipolar or safety pin appearance. So, kaya siya Donovanosis is because of this Donovan bodies na makikita mo on microscopy. So, ano ba yung itsura ng Donovan bodies? So, ito yung isang example ng Donovan bodies. So, itong mga nakikita nyo na mukhang safety pin or perdible, yan, di ba? Kaya siya bipolar kasi parang yung magkabilang dulo niya ay mas dark. Okay? So, mukha siyang safety pin. So, yan ay yung bacteria mo. Kung makikita nyo, there are clusters of bacteria within macrophage, no? Or a big cell, a mononuclear cell. So, in-engulf siya nung cell, yung mga bacteria. So pag nag-silver stain ka, ito yung magiging classic appearance niya. So, ito yung buong to, ito yung mga Donovan bodies. Okay? So, ito cluster na to. Yan. So, ito siya in real life, guys. So, meron kang macrophage or giant mononuclear cell. Tapos meron kang mga organisms sa loob na bipolar. Pag isuzoom in mo pa yan, mukha yang may dalawang darkened ends, dark ends. So dahil doon nagmumukha siyang perdible or safety pin. So your safety pin appearance or bipolar appearance or your Donovan bodies those are buzzwords for granuloma inguinale, which is caused by your Klebsiella granulomatis. Okay? So, kaya siya donovanosis dahil sa Donovan bodies. Ayan, so balikan na natin. So, sino yung may beefy red ulcer? Beefy red granuloma inguinale. School of fish appearance on microscopy. School of crying fish, so chancroid or chancroid. Saan ulit si Donovan bodies? Granuloma inguinale ulit yan. Basically, si safety pin appearance yan yung appearance ng mga bacteria mo within a mononuclear cell na giant. So yan si granuloma inguinale ulit or donovanosis. That's the other name for it. So saan makikita si silvery spiral organisms, yung mukhang slinky on dark field microscopy? It's in your cases of syphilis. So those are your high-yield buzzwords in OBGYN microbiology, and that's the end of my OSI lecture for you guys. I hope you learned a lot in pharmacology, pathology, and microbiology and our specialty.